it's always hard to follow Peter Nicholson, right? Pretty clear, pretty concise, pretty compelling. I'm going to respond kind of in three parts. The first part, I'm going to thank the Academy for what you do. Dr. Cairns, others, after being out for a while and now back in the game for 5 years, I'm just amazed at how much the Academy continues to do to advance the cause of Canada. You know, the return on investment framework that we're now using to try and determine how we can get a bigger bang for our buck on health research in this country. The recent report by Dr. Allison, I believe, talking about some of the challenges in the area of dental health care and particularly dental care for children. These are all examples, I think, of the important role that the Academy plays. So I'd like to thank the Academy for continuing to play that leadership role here in Canada. And I know that there are many fellows in this room of the Academy who are also affectionately known as our VPRs at HEALTHCARECAN, formerly CAHS. So I want to congratulate today those who are the new inductees to the Academy. As I said, I'm going to try and address this topic in 2 or 3 bites. We'll focus in the last part around what I consider to be sort of the winning conditions for fully capitalizing on our health research endeavor in Canada. But before doing that, and I'm hoping this thing works, there we go, I'll give you a brief, sort of very high-level review of where we are with HEALTHCARECAN. There's a number of brochures out on the table, prepared by my colleague Tina and my staff. Please take a look at them, and you get a better sense of where we're at in our journey. I will then go on to talk, as I said earlier on, about what I consider to be maybe some of the special conditions, market conditions for health care, of course, and then of health care research in Canada. And where we, HEALTHCARECAN, see some of the initial initiatives taking place to move forward under the banner of the Academic Health Science Center's Action Plan. And then, of course, over the course of the next 2 days, I intend to listen very carefully to what more healthcare can do to advance the health research agenda. So this is our statement of purpose. Many of you will have known and been aware of the Canadian Hospital Association and Healthcare Association going back 85 years. And of course the Association of Canadian Academic Healthcare Organizations, which has been around a little bit, not quite as long. We came together in January, formally. They asked me to take on the job of founding president and CEO of the new organization in March. And between then and now, we've got a new name, a new logo, and a new mission, as set out in this purpose statement. In essence, what we've been asked to do, what I've been asked to do, is to serve as the collective voice for healthcare organizations across the country, with the implicit understanding that that voice hasn't been strong enough relative to other voices trying to shape the health policy agenda, the science and technology agenda across Canada. As I went around in what I've called affectionately my 90-day challenge, crisscrossing the country at least twice and meeting with over 200 leaders in healthcare and VPRs across the country, it became clearer and clearer to me why we exist. We exist to do 3 things, and they're intersecting and interdependent. The overarching objective is to provide and support and encourage innovation in healthcare in support of service excellence. Not just in the academic health science centers, 43 of them across the country, but certainly starting there. Big job to do in terms of continuing to advance the research agenda, but in context where science and technology is in service of health, not the other way around. And third, the growing demands and needs for professional development, capacity development, leadership development, managerial expertise. There's a growing skills gap in this country as we look at the complexity of healthcare and the toolbox that managers and leaders have. The objective is to go from the current 40 members, most of the academic health science centers across the country, plus the umbrella organizations that were previously part of the Canadian Hospital Healthcare Association, our current membership, but the goal is to expand membership over the full continuum of healthcare. So let's move to the next part, which is kind of reflecting on, and I did have a chance to review Peter's slides, his PowerPoint ahead of time. And I guess one of the reasons I was invited is I'm a health economist, and I'm going to give you one view from one health economist. Of course, economists are notorious for never agreeing with one another, right? I don't know if you have been following the Roosevelt story on TV, FDR's story, but FDR famously once said, I'd give my presidency for a one-handed economist, because economists are constantly saying on one hand and on the other hand. I think it was in this very room that my friend Angus Reid one time introduced me as an economist, and he said about economists, he said, you know, if you laid them all end to end, they'd still not come to a conclusion. So you're getting one view from one health economist here. But it is a view that's based on some 38 years in the business of health and healthcare. So let me begin by agreeing with particularly the diagnostic part of Peter's talk. We have had a track record of weak innovation performance in Canada. And we continue to underperform in terms of capitalizing on the great ideas and great research that's done in this country. As an example, I just ask you to look at the dramatic events over the past few weeks around Ebola and the outbreak of Ebola in West Africa. With research conducted at our Level 4 lab in Winnipeg, funded, I understand, by DND research, aimed at what? Protecting us against bioterrorism. We can be forgiven if we were slightly frustrated when reading in the newspapers that there's now a production problem, not here in Canada, but in, I believe, a Utah-based production company. You know you've lost the commercialization initiative when we now call internationally the vaccine ZMAP, not ZMAP. ZMAP, not ZMAP. For me, that's just one example among many examples of late of where we seem to have all sorts of good ideas but have trouble capitalizing on them here in Canada. Peter's also quite right that we're junior partners in North America when it comes to health research or capitalizing on health research. I don't know how many of you remember, it's been many, many years ago that Arnold Relman, the former editor of the New England Journal of Medicine, wrote an article about the great medical industrial complex in the United States. In that article, as I recall, what he made was an argument that there's one reason, among many, why the United States continues to outpace other industrialized countries in terms of healthcare spending. I think they're tracking at 18% of GDP now, and we're still at about 11.7 or 12. One of the reasons was that they can afford it, because they can realize the economic rents on all the technologies, devices, and pharmaceutical products that they produce in the United States to help cross-subsidize the over-expenditure in health and healthcare. So we are junior partners still in the North American medical industrial complex. One of the things that Peter didn't mention, I think, in this context, and I'd like to have some more discussion about it, the former Bank of Canada Governor, Mark Carney, often talked about this $500 billion, or $500 billion in what he called dead money, right? Dead money going nowhere, and of course, taking us nowhere fast. How do we get Canadian industry to part with that $500 billion of dead money to help take ideas from bench to bedside to boardroom? I also agree that it's an ecosystem. It's not a production line. It's not a pipeline. It's not a linear model of innovation. Where's Diane Fangood? She's on a mission. She's on a mission. She says, where are you, Diane? There you are. If you accept that healthcare is one of the most complex, dynamic, maybe non-adaptive system on the planet, why would you expect reductionists, linear approaches to solving the challenges of health and healthcare research to work? Right, Diane? Did I get that about right? Good. Where I think there's a bit of a fork in the road, and this is where I go from sort of the diagnostic to the prognostication, is the nature of health markets. We all know that health markets don't behave like regular markets. That's why you have governments involved in health insurance and the financing, at least, if not the delivery in other countries, finance and in delivery of other countries, of healthcare. You know, what are the reasons for market failure? Asymmetry of information between the provider and the consumer of healthcare. Massive externalities, both positive and negative, when it comes to your purchases of healthcare and how you value that and how you value the purchase of healthcare of others. Those are the kinds of market condition failures that exist in the health and healthcare system. I just asked the question, what's the nature of the markets for healthcare research? Do they share some of the same limitations as the market for healthcare? And there's a great book that's just come out after a number of years of research by Harvey Lazar, a former senior policy guy here in town. He now resides out in Victoria, looking at 60 case studies looking back over 10 years. And he came to the same kind of conclusion, Peter, for healthcare as you came to for the whole economy. That we've been kind of going along. That there's a paradigm freeze. Structures, processes, legislation. You know, I was involved in the Canada Health Act. That's 30 years ago. And we haven't changed anything since then. That's right, same deal. So again, just as we look at the market for healthcare to start, I've spoken to the sources of market failure for healthcare. Here might be some of the sources of market failure for healthcare, the market for healthcare research. Marked by increased concentration consolidation on the supply side. We have anything but freedom of entry and exit into the market in Canada. You've got monopolistic or oligopolistic supply globally, let alone here in Canada. You've got downward price rigidities. What do I mean by that? Are there any ophthalmologists in the room? We've gone from being able to do from 3 a day to 7 a day, right? But no change in the fee-for-service schedule, downward one. That's why we have a few not too badly off ophthalmologists, certainly here in Ontario. Right? So downward price rigidities. Name me another industry where you have innovation, technological advancement. Whoa, I've got 54 seconds left?
You got 54 seconds. No, 52.
50, 21, 49. Oh boy, I'm in trouble here. So any wonder why we have a low BERD, business expenditure, research and development, GERD ratio? On the supply, on the demand side, service imperatives squeezing out teaching and research. Dr. Kearns, you talked a little bit about that. Procurement historically fragmented, but increasingly monopolistic as you see the premiers starting to work together in terms of things like group purchasing of generics and of brand names. I guess I'd leave this as a challenge. John Kenneth Galbraith talked about the need to strive for workable competition, right? Where we look at how we sell our strengths, buy our weaknesses, and look for a countervail between the supply and the demand side, given that we have imperfect markets. Creating the winning conditions. We can do some things on the supply side. We need to collaborate to compete. That's why I'm a big fan of the NCEs that we started, Cy and Rick, like 15 years ago, I guess, in the health area. I'm also a big fan of SPORES for the same reason. It forces our health care researchers to look at how they can even better collaborate together. Because if we don't collaborate together, we're not going to be able to compete internationally. Engagement strategies, the importance of academic health science centers as part of that ecosystem that you talked about, Peter. 80% of health research in this country goes through academic health science centers. Okay, so it's necessary but not sufficient when you're starting to fool around with the health and healthcare research enterprise that you talk to presidents of universities. You also need to talk to the presidents of academic health science centers in this country, and that hasn't been done. We need a cultural shift. How is it that Canada? There's a wonderful article by the president of University of Alberta talking about why it was 20 years ago that we had our last Nobel Prize laureate. And we keep blaming small markets, by the way, for why we can't capitalize on our health research investments. Anybody want to guess which country had 4 Nobel Prize laureates in the last 10 years, according to the article? Israel. Anybody want to guess which country has the highest number of patents per capita? Israel. The population of Israel is what? 6 million. So don't blame the fact that we got a small market for why you can't capitalize on your health research investments in this country. I'm going to have to... Uncertainty. The biggest killer of innovation and capitalizing on innovation is uncertainty. And there are so many aspects of uncertainty in this country. Procurement policies. Who's calling the shots? The churn rate among who's actually making the decisions about who's going to buy what products, what services. Uncertainty around the constantly shifting sands of CIHR and other funding. That's a killer. Uncertainty. It's a killer for careers. Another part of the article by the president of the University of Alberta talked about the need for greater mentorship, a culture of change. Wind it up, Bill. We need to move, in the words of Premier Giz, the chair of the Healthcare Innovation Working Group, co-chair, we need to move from a culture of innovation by accident to innovation by design. Aligning the processes, the procedures, and the policies in much the same way as we think about lining up Swiss cheese in an unintentional way to help explain why things go wrong. In an intentional way, can we line up those policies, practices, and procedures to help ensure that things go right? We're trying to create the winning conditions. You'll see an action plan out there that's been prepared by and for deans and CEOs from across the country. Please take a look at it. We're trying to streamline the clinical trials process in Canada with the creation of the Clinical Trials Centre in collaboration with RX&D Canada and CIHR. We're announcing today the unveiling of Innovation Sensation. How can we shine a light on the 5,500 reported stories on innovations in health and healthcare to get the public engaged? And if we don't do this, I agree with Peter. The blue oceans can turn to a red ocean in a nanosecond. You know, I agree with the clarion call, the call to action that Peter's sending to all of us here, saying we got to change the way we're doing business. We got to change the culture of health and healthcare research in this country. Thanks for